Just pull it up. So let's talk about hemodialysis for a second. So if someone comes in and they're in acute renal failure, so you can have CKD, chronic kidney disease. I always harp on this, right? So this is like one of my big pet peeves. There's a 90-year-old who fell and their creatinine's elevated. What do I always say? And then the residents put acute kidney injury. And I'm like, no, that's not a 20-year-old who bled to death, who has AKI from acute tubular necrosis because they're in hemorrhagic shock. They're 90 and they fell down. They have underlying chronic kidney disease, okay? So there's stage 1, 2, 3, A and B, 4 and 5. Don't quiz me on the GFRs and the creatinines. You can look, that's a lookup type thing. But stage 5 CKD means they need hemodialysis. So it's time. What's the most important electrolyte that I'm probably always concerned most about here? Yeah, they're potassium, okay? So now they're hyperkalemic, they're in renal failure, they're anuric, they're not making any urine. So they need dialysis, and this could be, in the acute setting, how do I administer hemodialysis in the acute setting?
Like a catheter?
Yeah, a hemodialysis, an HD catheter. So this is a central line. It's a central venous catheter. The size of it is a lot larger than the 7 French, like CVC triple lumen. This is like a 10 French or so. Correct me if I'm wrong, anybody. I forget. But this is a dual lumen. Okay, so it's got 2 lumens. It's got the arterial and venous port, because that's what we're going to do to dialyze them and put them on hemodialysis. So typically, right IJ is preferred. We can go on the left side, but it's a little bit more of a windy path. Because again, and then the problem we always run into too is in an emergency type, trauma patient that needs CRRT or acute hemodialysis because of renal failure, because they bled to death, like we're saying, we can put it in the groin. You need to make sure you have a long enough catheter, especially if it's a big patient or an obese patient, because a lot of times we'll grab just a 15 centimeter. That's like the standard med comp hemodialysis dual lumen catheter. Sometimes we'll grab that and put it in. Bad decision. Why? Doesn't go high enough. So it ends up landing in, say you put it on the right side, it ends up landing in the right common iliac vein, and the dialysis doesn't work. Then the nurse is calling you all night because it keeps clotting. And they try to do like cath flow or whatever they think it might be clotted, but it's actually just sucking up against the wall of the vessel. It needs to be long enough to be in the inferior vena cava. And this one needs to be just like in the perfect spot as well at the superior vena cava atrial junction, right there to get a good working catheter. So that's a temporary hemodialysis catheter. We can then transition this if we think they're going to need more long-term to a tunneled one. You guys understand what I mean there?
I don't really know the difference.
So a temporary catheter of any sort is just going to be like catheters in, central line, medcomp, whatever. If we want that to be more long-term, we tunnel it. So any tunneled catheter, like a port for chemotherapy or a hemodialysis catheter that's tunneled, you have 2 separate incisions to where you tunnel it and then it goes into the vessel, just a much lower rate of infection. That's the whole purpose for tunneling a line. So we would then tunnel it, but now say you're seeing somebody, like say you're a nephrologist or a vascular surgeon in the clinic, and you're seeing somebody with CKD, and we're preparing, we know that they're moving towards, this isn't acute, but we know they're moving towards probably requiring hemodialysis. What would you do then for them? Yeah, so then you see, today we're just talking about fistulas, baby, all day. So you make a fistula. Who would have thought fistulas are so exciting? And you start where?
The arm. Or like
yeah, where on the arm?
AC.
Nope.
Or radial.
Yeah, distal. You want to start distal because you burn that, then you go here, then you burn that, then you go here, then you burn that, then you go somewhere else. We got, like I did a lot of access in residency, and we get creative, especially with some of the crazy surgeons I worked with. And so you want to start here. Do you know the name of the fistula here? A semino fistula. So that was who invented it. This is a radiocephalic fistula, radial artery cephalic vein fistula. Start distal. So I just said, tell me about the, and we want it to be a native vessel. graft is a less good option, if you will. We want a native vessel. So tell me about that rule I told you guys that we were going to look up, because I forget all of the rules. So what's the rule of sixes?
Vein diameter should be at least 6 millimeters.
Yeah, okay, so diameter should be, and so we're checking this with what? How do I know?
Ultrasound.
Yeah, with an ultrasound. Okay, so the diameter of the vein should be 6. Something about velocity being?
Well, the flow has to be at least 600 million.
Exactly, so that's velocity. That's what we were talking about yesterday in rounds with the carotid, remember? So velocity is just 600. So you want a good velocity, a good flow. Velocity is flow. Okay, what else?
And then the fistula
I
should
think
be...
6 weeks for it to mature. Is that right?
Yeah,
Yeah.
metric
Yeah,
is good.
6 weeks for it to mature. So you do the operation, you don't just cannulate that thing right away. It needs to do its thing. What else?
The straight segment cannulation is at least 6 centimeters.
Straight segment. Oh, like the area that you're gonna, because these are big needles that we put into the fistula. So yeah, so you need at least 6 what centimeters?
6 centimeters.
Yeah, okay, that makes sense. So 6 millimeters diameter, but 6 centimeters of like landing surface, if you will.
And then the depth must be less than or equal to 6 millimeters from the skin surface.
Yeah, that's true. So you also don't want to be super deep. It has to be superficial. So these tend to bleed. We get these in the ED, bleeding fistulas, where you have to put a suture in it, and then typically it's a venous outflow obstruction. So you don't just put a suture in it and send them home. You control the bleeding, and then they need a fistulogram. Okay, so either interventional radiology or vascular surgery is going to figure out what's causing that. It's typically a venous outflow issue, and they typically have to stent that. And then what's other forms? So this is hemodialysis, but what are other ways we can administer dialysis?
Peritoneal.
Yeah, so you can, again, so that's a tunneled catheter that we put in laparoscopically. So the catheter's in the peritoneum, and that's done at night. So hemodialysis is on like a Monday, Wednesday, Friday, where the patient has to go to a dialysis center or unit and have the dialysis done. Whereas the advantage of PD, peritoneal dialysis, is we can do it at home at night. So some patients prefer that methodology.
Do you is it overnight? Like you just sleep
Yeah,
with it?
Mhm.
Oh, okay.
that's when it runs. I don't know the exact time. Someone can help us, but yeah.